otherwise unmute your mic. So apologies for the change in schedule. I just thought I'd have one slide on why. Had an emergency hindquarter amputation, not a common procedure, and a very extreme procedure. The clinical picture on the right, I admit, looks very much like a dog's breakfast, but it's to show you the end result of a failed hip replacement in essence, and a PJI gone wrong, as it were. And just to mention the difference between a hindquarter amputation, a hindquarter amputation, which is through the sacroiliac joint and the pubic symphysis, and a hip disarticulation, which is obviously disarticulating the hip. And a hindquarter can be extended into the sacrum, or it can be, that would be extended hindquarter or a modified hindquarter, which would include less of the ilium. So that's why we were, well, unfortunately we had to change the date. The picture on the right, basically I've tried to show some errors. This is the sacroiliac joint. So this is the patient's head at the top, other leg at the bottom. This is sacroiliac joint. Pubic symphysis is the main vessels, and the sciatic nerve would come down there where the leg's been taken off. Adductors, apologies, gluteals. Right, anyway, enough of that. See if I can advance the slide. Right, so osteosarcoma. First, we'll just recap a little bit on how to go through an X-ray. This is a very common X-ray that one would find with an osteosarcoma, except for the fact that you'll see it's a little bit more diaphyseal, which is more common with a Ewing sarcoma. Okay, you remember our mnemonic leaf, which is for diaphyseal tumors, where the E stands for Ewing's, that's more diaphyseal. Osteosarcomas are usually more metaphyseal, but can extend into the diaphysis. It's a very good example, actually. And I wonder if I zoom in on, no, I won't, yeah, zoom in on my computer, of what I would call onion skinning, and that's more common with Ewing sarcoma. You can see the different layers of periosteum causing the onion skinning. And so, but this was a osteosarcoma. I've lost my mouse point. Okay, there's back again. So anyway, we see, so going from the outside in, we need a mnemonic. We first got to describe the X-rays. We can see it's a skeletally immature patient. So it will be a young patient. The growth plates are open, so probably in a teenager. We see a soft tissue mass with a periosteal reaction, Codman's triangle, okay, forming. As the periosteum lifts off, it tries to slow down the process by laying down bone, and that causes a Codman's triangle. And you'll get these sunray spicules or sunburst, and these are the Sharpley's fibers. Sharpley's fibers are what attach the periosteum onto the bone, and as they lift off, they get calcified and look like a sunburst appearance. And then we've got the matrix, which is in an osteosarcoma, there will be blastic parts and lytic parts, but we see this very wide zone of transition. So there's no distinct border between what is tumor and what is bone. Okay, and this is at risk of fracture because of the cortical erosions and involvement, and about 10 to 15% of the time we see a pathological fracture in osteosarcoma patients. Okay, so we've mentioned some of those things, or the other name for sunburst or sunray spicules is hair on end. So this is my approach to describing an X-ray. You don't have to use it. You can use whichever one you prefer, but I'll start with the image, patient and date, mention whether it's skeletally mature or not, because that'll help you with your differential diagnosis, whether it's a single or multiple lesions. Lytic is always important. That implies a more aggressive process and more possibly malignant. Location, where it is, where in the bone it's involved is very important, because like I mentioned with the leaf mnemonic tumors in the diaphysis, the differential is different from that of the metaphysis or epiphysis. And remember, in the epiphysis, it's likely to be, well, certainly a benign range. It'll be ABC, GCT, or chondroblastoma. Then we look at the matrix, and if the matrix is osteoid, then we know it's an osteoid-producing tumor, like an osteosarcoma. If it's popcorn-like, then we know it'll be more towards the cartilage range of tumors, like a chondrosarcoma. Zone of transition, of course, is important. So these three things help me the most to decide on my differential. If the zone of transition is wide, we know it's more aggressive and more likely to be malignant. Cortical destruction is important, helps speak to the aggressiveness of the lesion and the potential for pathological fracture, subperiosteal reaction as well. Don't forget infection when looking at that. And then, of course, soft tissue extension. Some tumors will extend into the soft tissue, while others won't. And then mention if it's near or in a joint, as this will affect your management. These are the things that you can go through when you've got time. Osteosarcoma is quite a long topic, and I don't want to, I want to get through it and before you get tired, as well as Ewing's. But we can see it here. This is why we mention whether it's skeletally mature or not. A lot of our primary bone tumors will happen in this age group, maybe a little bit in this, as we can see here, osteosarcoma, Ewing's, and then as we get to 40 plus, we get more towards metastases and secondary peak in osteosarcoma. Location is important, and again, as I've mentioned before, so osteosarcoma more metaphyseal, diaphyseal, Ewing's more diaphysis, chondroblastoma more epiphyseal. So lysis and zone of transition also give you an idea, as I've already mentioned, about the aggressiveness of the tumor and whether it's malignant or not, and whether you need to take it more seriously. It's a little bit of a complicated slide, and it was difficult to try to put this together in a manner on a PowerPoint slide that made sense. But once I've described a lesion, I would suggest you, instead of, and remember, I've always said describe it once, try not to become circuitous in your description, mentioning things, the same things over and over again. So once you've described the X-ray, move on to your differential, which of a bone lesion, in my opinion, has three main branches, being infection, neoplastic, other, or metabolic. And then from those, you can develop further differentials. But if you start in this fairly logical and predicted pattern, you will cover most of your differential. And I see some of you, in describing an X-ray, a little bit like deer in headlights, which is very understandable in the beginning, but you're searching for names of things. But if you have an approach, those names will come, and you'll find you're able to talk much better through the oral. So from infection, you can look at acute, obviously subacute Brody's abscess. From other metabolic, you can look at hyperparathyroidism, and then of course neoplastic is divided into benign and malignant. And then from there, I would break it down into location, and from location, break it down into what you remember. So osteosarcoma is definitely the most common primary malignant bone sarcoma in humans, and it most often occurs between ages of 13 and 16. And if you remember, I've said that these are the three main sarcomas that you need to worry about, in my opinion, for your exams and for your general orthopedic knowledge. Osteosarcomas we've started with because it's definitely the highest prevalence, moving on to Ewing's and then chondrosarcoma, which is actually fairly rare. In osteosarcoma, we get a second peak in the 60-year-olds and above, and there are quite big differences between these two groups. In the first group, we have young children being a primary malignancy, and of course they won't have had any more treatment. But in the 60s and above, we see it in different sites. It's definitely got a worse prognosis, and its causes are different. The causes are more towards secondary causes of osteosarcoma, so radiation-induced or Paget's osteosarcoma. And these patients have a high risk of having macrometastatic disease at presentation, and of course this affects their survival. So a bit of differences again, just elaborating on those two groups. Childhood and adolescence, it's still a very small proportion of childhood cancers, being only 6% in bone. The peak is between 13 and 16, and this is thought to have to do with the growth spurt, and most amount of growth being done during this time. And because there's a rapid turnover in cells, there's more chance of having a genetic hit or secondary hit go wrong. Osteosarcoma, more common in boys. For some reason, blacks and other races, I don't mean to be racist here, but and whether to mention, I don't know really whether to mention it or not, but blacks and Asians, less common in white kids, and these are often contrasting differences, where we see, for example, in the secondary, osteosarcoma is more common for whites for some reason. We're not sure about our numbers in Africa because we don't have very good databases at the moment, but there is some evidence to show that we may have double the number of osteosarcomas than in the rest of the world. Adult osteosarcomas are most often secondary, and think Paget's and radiation-induced. And the radiation-induced ones normally occur 12 to 16 years post-therapy. And you'll see from our follow-up that we often follow these patients up for 10 years, but unfortunately that doesn't mean that they're cured and are out of the woods, as they can get these secondary osteosarcomas later. There are some benign conditions like fibrous dysplasia and McCune-Albright's, in which can develop a 10% chance in McCune-Albright, certainly, of developing osteosarcoma. In the childhood adolescent type, they are more appendicular, so metaphyseal, as we've discussed, around the knee, proximal humerus, whereas the adult osteosarcomas are more axial in location around the scapula often, or in the spine. They're more metastatic, and the chemotherapy is tricky. And often in these, when they're resistant to chemo or they've had chemo before, we sometimes treat them with radiotherapy. And some of the alkylating agents like cisplatinum, which we use, can eventually lead to secondary, that we use in the childhood adolescent type, can lead to secondary osteosarcoma later in life. So where is it found? We've already mentioned during the growth spurt, around the growth plates, and most commonly around the knee. This is an example of a parosteal osteosarcoma. So it's parosteal osteosarcoma is more a low-grade osteosarcoma arising from the surface of the back of the knee most often. And its treatment is mainly surgical. There's not much chemotherapy that's effective there. And then a very small proportion, very distally in the appendicular skeleton. Chemotherapy, as you may have heard me mention before, has really turned around the survival of osteosarcoma patients, where 30 years ago, 80 to 90% were dead at 5 years, where now our survival rates are up to 60, 70%. And this has led to the theory, you might remember my 80-20 rule, where 20% of patients presenting with a primary bone sarcoma will have macrometastatic disease. And there's a theory that 80% have micrometastatic disease at presentation, because because of this fact here, where 80 to 90% were dead at 5 years before chemotherapy, so we're giving chemotherapy now, we're giving it early, and we think that this helps in reducing the burden of disease and mopping up those micrometastases. And that's why giving chemotherapy is urgent. We want to really give these agents quickly to mop up those metastatic disease, and also it gives us a period in which we can do surgery. Because we need to do surgery, but we are conflicted by the fact that we have wounds that need to heal, bone that needs to grow if we're doing a vascularized fibula, and because chemotherapy affects all of these things, we give chemotherapy that gives us a window in which to do our surgery. Most of the time, sarcomas, as you know, spread via lymphatic system versus carcinomas, which are, beg your pardon, carcinomas are lymphatic, sarcomas are hematogenous, and because of this, they get filtered out in the lungs, which is the most common place to get a metastasis, and then bone being the next most common place, either in the same bone, so with a satellite or a skip lesion. Satellite lesion being in the reactive zone of the tumor, so much closer to the tumor. If you think about the Earth, its ozone, let's say, in the satellite, that's a satellite lesion, where something like the moon would be a skip lesion. Okay. If we do have bony metastases, is of course a worse prognosis, because your burden of disease is greater and the less chance we have of chemotherapy being able to combat that. But having said that, this is quite an important point, because a lot of people assume that if a primary bone sarcoma presents with metastasis, that patient is now palliative. Okay, but that's not the case. It's not very high, the prognosis and the survival rate at 5 years, but it's still possible to save that patient's life. And 25% of patients at 5 years who present with macrometastasis will survive. Okay, so limb salvage, that impacts our decisions around limb salvage, and it impacts our decisions around giving chemotherapy and how we treat these patients. We often get criticized in this specialty by spending a lot of money. However, limb salvage is cost effective and has many other benefits, and we mustn't write these patients off. So although overt metastatic disease has a worse outcome, we must not write them off. The most significant prognostic factor that we probably have is the presence of metastatic disease. However, these can be resected, whether it be cherry picking the bony lesions, whether it be lung resections, pneumectomies, or lobectomies. And there is this entity called pseudometastases in 25% of the cases, where often we see these indiscrete nodules less than or sub-centimeter, is a term the radiologists like to use. And they're indeterminate, and they can often be thought to be metastases. However, they either persist and don't grow, or they disappear. We give the same chemo whether the patient has metastatic disease or not. So how do osteosarcoma patients present? These patients present mainly with pain, and this is because of the periosteum stretching. Obviously, the periosteum is well innervated, but it's also because the tumor invades the bone, weakening it and causing microfractures, which the inside of the bone especially is very well innervated. Of course, sudden pain implies either an impending or already fractured bone. And about 10 to 15% of pediatric patients present with a pathological fracture. And for some reason, pain and secondary sarcoma don't go together, and it's more uncommon in adults. You may get a soft tissue swelling, and remember the 5 signs of it being deep, firm, fixed, with skin changes being prognostically very high for something malignant. Okay. Systemic, we often hear mention of these systemic symptoms, but however, they're uncommon. They occur in about less than 20% of cases. And they include fever, cough, night sweats, malaise, very much like TB, but this implies advanced disease. And so not all of our patients will present like that. It's something too important to mention, but just know that it is not every patient. Even if a patient does not have these symptoms, it does not mean that they don't have an osteosarcoma. I wouldn't focus too much on laboratory tests. Everyone goes straight to, which is understandable, calcium and phosphate, and magnesium. They're more important in carcinomatous and metastatic disease. We've got a high burden of disease, a very high bone involvement, and a very high release of calcium into the bloodstream. Osteosarcoma is generally, I don't bother to take a CMP when looking at an osteosarcoma. What I'll do is a FBC, UNE, and that's really for my anesthetists and to sort of plan biopsy, etc. I will do a CRP and an ESR as a baseline. It adds, they're not terribly expensive tests, and they add to the diagnostic profile. However, if they're not high, it doesn't mean that the patient doesn't have an early osteosarcoma. I do an LDH and an ALP, but usually after the diagnosis of osteosarcoma has been made, because if these are very high, they can help in prognosticating. But as you can see on the fourth line there, they're only high in 30 and 40% of patients, respectively. X-rays are undervalued. I think that they're very important. A lot of people jump straight to an MRI scan, but sometimes an MRI scan can be equivocal, and an X-ray, if it's got those signs that we saw in the beginning, can be quite helpful. What you will see on X-ray, if you have an osteosarcoma, is a mixed, usually sclerotic, and that's the osteoid, the immature bone that the tumor is producing, and that's a sclerotic blastic component. And then, of course, there will be parts of the tumor that are not calcified on that immature osteoid that's not calcified, and those will be lytic. If you see a purely lytic, something like I've shown earlier, and it's purely lytic, we think of malignant fibrous osteosarcoma, a fibrosarcoma, because those are usually not calcified, and GCT. If it's diaphyseal, remember Ewing's and lymphoma are two big culprits. And never always think about an ABC and the subvariant of osteosarcoma that looks like an ABC called a telangiectatic osteosarcoma, and an osteoblastoma you can add, because that will be blastic and it can be large. So when asking for an MRI scan, please ask for an MRI scan of the whole length of bone. That's important not only to plan the biopsy, to compare, but also to compare with your post-neoadjuvant chemo MRI. You want to see whether the joint's involved in the joint above or below. You want to exclude skip and satellite metastases. There's been a lot of comparison between CT and MRI scan, and a lot of the time CT is just as good. However, MRI has the edge when looking at your vessels, your nerve, and whether your knee joint or your shoulder joint is affected. It also, an MRI over CT also shows better your bone marrow margin. Sometimes the tumor can be very great, and you think you've got the transection point right, but there's some tumor that will go up the marrow, and MRI is better at showing you that. And we take what's called an imprint when we do the transection through the femur, which is take some of the bone marrow as a separate sample. We send that for histology to see whether there's any tumor there, to confirm that we have got that margin. And the workup for metastatic disease includes a CT scan of the thorax and upper abdomen. Some places do a CT chest, abdomen, and pelvis. However, you'll only get very little information on including the abdomen and the pelvis, because the osteosarcoma will metastasize to lungs, first of all, and then to solid organs like the liver, spleen, kidneys, as these are filtration organs. And the last thing, in order to get the rest of the skeleton, which will include the spine, the pelvis, and the limbs, will be a bone scan. And currently, at the moment, our protocol is to get a technetium-99 scan. Other places in the world are doing whole body MRI scans looking for metastatic disease, and they're also doing PET CTs. But currently, there's not great evidence to show that these are much better than a technetium scan. However, they may be useful in assessing treatment response. Okay, so PET uses SUV, or a standard uptake value, and those can be measured pre and post treatment to give you an idea of whether the tumor is responding to your chemotherapy. Okay, but whatever you use, be it MRI scan, being it PET CT, being it whole body MRI, you should use the same method throughout. I cover this in the introduction talk to sarcomas. The staging classification system we use is the musculoskeletal tumor society score, who's adopted the Anakin scoring. And that basically uses grade, site, and metastases to score the patient. Most of our patients are a 2B, which means that they're a high grade, and they're extra compartmental, which means they've, remember, a bone is a compartment, and so the tumor has grown out of that bone and into the soft tissue, involving more than one compartment. So on histology, we will see, you unlikely to get asked this, I think, less and less these days, but you may be asked on it and need to have something to say. But there will be malignant sarcomatous stroma. Basically, this means it looks nothing like normal bone. There's osteoid there, so you'll see this pink lace-like osteoid. I've got a picture coming up, with variable amounts of calcification and cells that look very different from one another. Okay. We'll also see the histological classification of osteosarcoma includes things like a fibroblastic osteosarcoma or chondroblastic osteosarcoma. Because these cells that cause the tumor are mesenchymal or connective tissue type cells, very early on in their differentiation, they are able to change, or it depends where they are, where their genetic mutation is in what substance they produce, be it more like cartilage, be it more like fibrous tissue, be it more like bone, and this will differentiate it into its subclassification. And unlike Ewing sarcoma, there's no chromosomal translocations associated with an osteosarcoma. So you can think of the histological classification as on the slide, where osteosarcoma being your umbrella term for all of these subtypes. I break it down to high grade, intermediate grade, and low grade. And then high grade, and you can think of both or all three types of grade, high, intermediate, and low, as having a surface variant. So the high grade has what's called a high grade surface osteosarcoma. The intermediate grade, its surface subtype is a periosteal osteosarcoma, so an osteosarcoma that looks like it's come off the periosteum. And then the low grade is the parosteal osteosarcoma, which I showed you a picture of earlier, and that's stuck onto the back of the femur. Okay, and then of the high grade, the second type is a classic conventional or intermedullary osteosarcoma, and that comprises 90% of osteosarcomas, and it can be subclassified then into what type of matrix it produces and what type of cell or stroma that the histologist can see on their slides. And if it's more like bone and it's osteoblastic, more like cartilage, chondro, and fibrous. And then you get some variants like the telangiectatic, which is very similar to aneurysmal bone cyst with very large spaces full of blood, giant cell rich, often looks like a GCT, and you've got to look very carefully for those undifferentiated cells with the mitotic figures. A small cell, pagetoid, high-grade surface, which I've mentioned up above, extraskeletal and post-radiation. Most of the time, and I've tried to rank them in order that or that they occur. So the ones at the bottom are least likely to occur, where the ones at the top are more common. These are two examples. On the left is a low power field. The right is a high power field. This pink, you probably only need to remember two things from this slide. One, this pink with no cells in it is osteoid, okay? It looks, the term is lace-like, lace being a type of material. And if you don't get confused, some people are not sure whether this light pink is the osteoid or the dark pink. It's the dark pink, and if you can't remember that, just try to understand that this is bone, there's much fewer cells in it, where this is the actual tumor, there's more cells in it. So it's a very cellular tumor that's producing this osteoid. And here in the high power field is just trying to show you that the cells are not the same. So there's a very big nucleus there, or nucleolus inside. This is a big cell, then you've got a small cell, and you've got a big cell that looks different from that cell, okay? But if you're getting into this type of discussion, I think you're doing well. So the treatment course of these patients is long. It's arduous, and you can see from our initial slides that it actually goes far past the initial chemotherapy and surgery. And it's obviously very emotive, and there's lots of links to the chain. You really have to have very good communication because it requires a lot of planning, a lot of timing, and a lot of drugs, a lot of complications, and the team needs to be on the ball if it's going to treat these patients correctly. And sarcoma treatment or cancer treatment really has defined the role of the MDT or multidisciplinary team. So this is the basic pathway. The patient presents usually to a GP or an orthopedic surgeon because they've played a sport and now they've got an ache around their knee. They've rubbed it for a bit. They've taken a brufen. They've gone to a physio, maybe a chiropractor, maybe an OT. Someone eventually does an x-ray and spots this. Then they get diagnosed with biopsy, and all of this is covered in the introductory lecture, so I won't go through it now. And they have their neoadjuvant chemo. Remember, this is to reduce the burden of disease, to mop up those micrometastases, and give you a window in which to do your resection and reconstruction, and allow those wounds to heal before you start your adjuvant chemotherapy. Once the adjuvant chemotherapy is finished, you then follow those patients up, which we'll discuss a bit later. Okay, so repetition is always good to try and drill these points in. So micrometastases, chemotherapy, mops it up, effective as an early treatment. I don't think it's important to remember these drugs unless you have an interest in sarcoma treatment, but our protocol here at is to use cisplatin and adriamycin. Adriamycin, the other word, don't get confused, is doxorubicin. So doxorubicin is, it's like the drug name, and adriamycin is like the trade name. Sometimes we treat with ifosfamide if we are concerned about a very aggressive tumor or there's been little response to chemotherapy, but that's in other parts of the world, that is their protocol. And the same principle applies with multi-drugs as it does with TB. the more drugs you use, the greater your effect. So you might hear of a MACI protocol, which is M, A, C, and I. There's a lot of centers around the world will use that protocol. But what you get also with adding drugs in kill rate, you also add to the complication list. So, and also these drugs are expensive. So, sure, no, so this is our protocol here. If there's a very low percentage necrosis after the resection, we add high-dose methotrexate. This chemo is given every 3 weeks. So you give chemo, then you wait 3 weeks, and you give another cycle of chemo, and you give between 3 and 5 cycles neoadjuvantly before your surgery. Radiotherapy, this is an important point. Remember, soft tissue sarcomas are treated with radiotherapy and very rarely chemotherapy. Bone sarcomas are treated with chemotherapy and usually not radiotherapy, except for Ewing sarcoma. And is one of the few sarcomas that is radiosensitive. Okay. So as a principle, soft tissue sarcoma is treated with radiotherapy, not chemo. Someone's taking notes, but they're coming up on my screen. Osteosarcomas are treated with chemotherapy, not radiotherapy, except Ewing's. Okay. Radiotherapy is sometimes given if like in the spine, for example, if you're not in a center where you can resect it, and the surgical morbidity would be very high. So surgery is very important. You want to remove all the tumor with a wide margin of tissue. We go through margins in that introduction talk. But we want to remove the tumor. It's like the chemotherapy in removing tumor burden. We don't want any local recurrence. If you do leave a positive margin, there's a 25% chance of local recurrence. If you get local recurrence, it means the prognosis is poor. Surgery can include amputation, limb salvage, or rotation plasty. I don't go into all the details here. That'll be in our surgical talk. Okay, so just a quick case example to show you what I mean and illustrate what I mean about if a patient presents even with macrometastatic disease and an aggressive osteosarcoma and a pathological fracture, it doesn't mean that they're palliative and they're going to die. This is a young girl. She was 13 when she presented to me. You can see on the chest X-ray on the right, she had a macrometastatic and bilateral disease. This is an axial cut through a CT scan showing that pulmonary disease. This was her osteosarcoma. You can see that it's metaphyseal, diaphyseal, Codman's triangle, periosteal reaction, soft tissue component, wide zone of transition, blastic, lytic, and she was of the pediatric population, so she was 13, she was in that 13 to 16 age group. She's had cortical destruction, so aggressive tumor, she's had a pathological fracture through it. Okay, so prognosis is poor. This is her surface of play. This is her 2 years down the line. She's on the bike, by the way. And she's had a distal femoral replacement. I didn't think she had a completely stiff leg 3 months after the operation. I thought she was just going to have a peg leg, but children do remarkably well. She had her metastatectomies by the cardiothoracic surgeon. She had a wide margin, so she's got no local recurrence. And she is, for all intensive purposes, free of current disease. Of course, she's still following up with us, and that may change, but we cannot detect any further disease on any type of imaging. So if tumor does recur, it recurs in the lungs. And the treatment depends really on the burden of disease. and it may require a resection. Usually we don't give further chemo at this point because it's usually not effective. What we may give would be palliative chemotherapy. The prognosis, if you get recurrence, is really determined by basically by whether you can cut it out or not. But your chances of survival at 5 years from the diagnosis of recurrence are about 20 to 45%. If you recur in any other place other than the lungs, which is usually bone, unfortunately your survival is much less. And that's usually because, again, the burden, you must think about the burden of disease, and that burden of disease is higher. If it's in bone, it usually means that it's in many bones. Other good prognostic factors, if you have recurrence in the lungs, of course, solitary means you've got a small burden of disease, you can easily resect that usually. If there's a longer interval from time of initial diagnosis of your osteosarcoma to the time of diagnosis of your recurrence, the longer that is, the better. And then if you are able to treat them then and get rid of that metastatic disease, then they have a better prognosis. What drugs to use in a second-line chemotherapy regimen is not clear. If we do give drugs, we give the same as our initial treatment. So overall, prognostically, we can save at 5 years 66 to 70% of patients with an osteosarcoma using chemotherapy and surgery that don't have metastatic disease on presentation. If it's in the axial skeleton, unfortunately, that number is much lower. That's because the ability to resect it away from the spine with a negative margin is much more difficult. If the patient presents with macroscopic mets in presentation, I use a rough 25% rule. So at 1 year, your survival rate is 75%, 2 years, 50%, 3 years, 25%, 4 years, 0. If you've got localized disease, okay, we've discussed that above, your histological response, that would be your percentage necrosis, your HUVOS grading. Remember, currently we regard 90% as a cutoff between good and bad. Anything less than 90, you cannot prognosticate whether 60 is better than 30. And likewise above 90, 95. So there are some studies that try to say that 95 is better than 90, or you need to get 100% in Ewing's in order to really have a good prognosis. But if you remember 90% above being good, below being bad, and your serum ALP and LDH or LH are prognostic markers, and they really speak to the amount of bone being turned over and the aggressiveness of the tumor. How do we follow these patients up? Well, from 0 to 2 years, we see them every 3 months. We do a clinical review and a chest x-ray. This, of course, to look for any worrying features. And likewise with the clinical review, we usually ask them whether they've got any pain that's different from the pain that they usually experience, whether they've noticed any new soft tissue lumps or bumps. If there's anything concerning on these two, then we investigate further. Clinically, if we think there's local recurrence, it's difficult. Usually these patients have a big block of metal inside their leg, and so you get a lot of artifact. With newer sequencing, like MARS sequencing, which stands for metal artifact reduction sequencing, we're better able to visualize the soft tissues around the area that we suspect. Chest x-ray, we'd use a CT scan. Other options than the MRI scan for assessment of local recurrence will include ultrasound or CT or PET CT. Okay, but we'll still get the scatter, but there might be a hot spot that lights up. From 2 to 5 years, we move to 6-monthly review, but the type of review is the same. And then 5 to 10 years, really, it's just a time period that changes, and we move to an annual review. There are some centres that this is different to. This is the UK London guidelines from the Royal National Orthopedic Hospital. which is the same as the Birmingham guidelines. The two main centres in the UK use these. People may talk about annual MRI scans or CT scans, but there is no consensus in what is the best method to follow these patients up in both timing and imaging. But using this, we will pick up most occurrences if it happens in a timely manner. So to summarize osteosarcoma, it's an uncommon primary malignant tumor of bone. It's a sarcoma, so it's a disease of connective tissue, of which bone is one. Okay, the rest of them being muscle, tendon, ligaments, nerves, blood vessels. Osteosarcomas produce a malignant osteoid or immature bone. The age distribution is bimodal, peaking in the 13 teenagers, 13 to 16, and over 65. The majority of these young osteosarcomas are sporadic, which means we don't know what the cause is. I often tell my patient that everyone asks me, why did I get this? 95%, I tell them 95% we don't know, it's sporadic. We think that there's the two-hit hypothesis where there's a genetic predisposition and then some kind of environmental insult. However, we don't know. It's not like the other 2.5%, which are genetic related, like Lee-Fraumeni syndrome, where there's a genetic aberration that's passed on in the P53 tumor suppressor gene, and those patients are very high risk for getting multiple sarcomas. So it's not like that. And the last 2.5% is cancers that we cause, and that's often in the adults that are the secondary neoplasms, whether it be from radiotherapy or chemotherapy, and then adults in Paget's. So those are the sum of, so minority, about 2.5%, Lee-Fraumeni being the big one. Don't remember these names, but just know that there are syndromes out there where there's a genetic mutation, and those patients and those families are at higher risk. Most of the patients present with pain, and typically of several months duration, because it's a deep tumor. It's a tumor of bone. It starts slowly, but its doubling time is 28 days. Remember that. It's often ascribed, it's in a young patient who's generally well, sporty, usually. So there's often a red herring being, I hurt myself while playing netball or cricket. And they've gone to see many different people before the tumor is big enough that someone does an ultrasound or an X-ray. Most important finding on physical examination is the soft tissue mass, really. And remember, the signs of a worrying sarcoma, anything larger than a golf ball or 5 centimeters, if it's deep, firm, immobile, non-tender with skin changes. Those are the clinical signs that one needs to look out for. There's the 80-20 rule. Most of 20% present with macrometastases, most often the lung, bone being next. Look for solid organs as well, like the liver and kidneys, which filter out our blood. Histological diagnosis based on this malignant sarcomatous stroma, which is this osteoid that does not have rimming osteoblasts, that has cells that are very different from one another and looks and is in a lace-like pattern. Conventional intermedullary high-grade osteosarcomas accounts for more than 90% of these tumors. When staging the tumors, basically staging, you've got to find out what's the extent or burden of disease locally and systemically. Please do an MRI scan of the whole bone so that you look for marrow involvement, skip and satellite metastases. Our protocol is CT chest and upper abdomen. Some people include chest, abdomen, pelvis. We do a bone scan, technetium 99, and some patients will do a 16 FDG PET with or without a CT scan. Those places arguably have higher resource potential, and they use those scans really to monitor treatment and as well as diagnose metastatic disease. Right, so that is osteosarcoma. So we'll pause for a couple of minutes. Stop sharing my screen. I just want to see, like, no one's really asked a question on the chat. Are there any questions at this point? Or was that all fairly self-explanatory? Radio silence. Has everyone gone off to watch TV? Okay. I will assume people are listening and don't have any questions. So I will share my screen and we'll get on to no questions. Okay. All right, cool. Good. So Ewing sarcoma is the next topic we'll discuss tonight. I have tried to compress it into something that doesn't go on for too long. Unfortunately, it's a bit, fewer pictures, and a lot of the stuff we will have covered in osteosarcoma. Some of you who have done some reading before may have read about PNET, or primitive neuroectodermal tumors. These all have a commonality with each other in chromosomal translocations and in their histological classification. And the newer classification has grouped these together to call it all one entity, really, being Ewing sarcoma or Ewing sarcoma family of tumors. Okay, so that's what the second part of tonight's talk will be. This is an example. It was nice to start with an example. This was an example of a 18-year-old girl who was a netball player. Very typical presentation, in that she presented with low-grade pain around the knee. Ascribe it to jumping and landing on the knee funny. Went to a GP, muscle strain, physio. Anyway, luckily went back to the GP, who then did an X-ray, fortunately, and caught a very early Ewing sarcoma before it had progressed. It's funny, these, I would have expected these X-rays to be the other way around. The osteosarcoma X-rays that I showed it initially in the first talk, and these, it just shows you one has to really do a biopsy and look at the histology before one can make a decision, because treatment is, as we will see later on, is very, very different. But the basic principles apply, except in this case, we don't have a very, we can see the hamstrings, soft tissue, musculature, a very nice X-ray, at a good exposure, but doesn't show any soft tissue component. There's a little bony swelling. One could argue that that might be a periosteo reaction there, but certainly nothing like the onion skinning that we saw on the first set of X-rays. What we do see, though, is a very wide zone of transition and a lytic lesion. Okay, we can see it. You're not sure where this lesion ends and where it begins. The other important part to note is that the matrix of the lesion is all lytic. Okay, so there's no osteoblastic component to it, which will differentiate it from something like an osteosarcoma. Okay, and also the other strange thing is it's metaphyseal diaphyseal, where we would expect to see an osteosarcoma. On that point, if there is no blastic disease, it doesn't mean it's not an osteosarcoma, but just one keeps our differential broader. I would have expected this lesion to be slightly up in the diaphysis. And no, I haven't confused the X-rays. I double checked. This is what the histology will look like. And some of you will know that these are all small, round, blue cell tumors. Okay, because they look like this. They're small, they're round, and they're blue. And that's the differential will include things like Ewing sarcoma and the Ewing's family of tumors, but also leukemia, lymphoma. But I think in the pathology, if you are asked pathology, it's going to be pretty gross, okay? Not as in disgusting, but as in obvious. If you see the histology slide on the last talk, that is most likely, well, 99% of the time, that's going to be an osteosarcoma. If you see something like this in an orthopedic oral, it's most likely going to be Ewing's, and you just need to have a differential, okay? And when we do chondrosarcoma, we will see a cartilage slide, okay? And then when we do some benign tumors, you'll see a fibrous, but you're either going to see something that's fibrous, something that's bony, something that's small round blue cell, and something that's cartilage, okay? So all of these, the Ewing's family of tumors, all have a very similar or same histogenetic cell of origin. Okay, they have similar histology, similar immunohistochemistry, and they all share this non-random or repeating chromosomal translocation, which is on chromosome 22. Okay, you don't have to remember T11, Q22, and all this kind of jazz. Just try to understand the basics of the differences between osteosarcoma and Ewing's, because that's a nice question to ask. 10 marks, describe the differences between the two. Osteosarcoma does not have a chromosomal translocation. Ewing's does. The differences in the histology, the differences in X-rays, etc. Okay. This is PNET primitive neuroectodermal tumor. This is Ewing sarcoma of soft tissue. So we do get osteosarcoma of soft tissue less commonly than Ewing sarcoma. We do see extraskeletal Ewing sarcoma. And this is something about a chest wall, can I remember? So Ewing's and osteosarcoma will share a lot of the same principles. Survival, however, in Ewing's is slightly higher than osteosarcoma, and this has a lot to do with it being more sensitive to treatment. So along with the chemotherapy in Ewing's, we add radiotherapy, and it's a radiosensitive tumor. Okay. The other important principle to remember about Ewing sarcoma is that it's considered a systemic disease. A little bit like the principle of the 80-20 rule, osteosarcoma, micrometastases, and disease burden. Ewing's, one of the differences in the workup of Ewing's will be a bone marrow biopsy. And this is used as a prognostic and treatment decision-making factor. Ewing's patients will have a bone marrow of the sacrum to look for this disease, and if it's found in the disease, it means that the prognosis is worse. Okay. And a little bit like osteosarcoma, just because a patient presents with advanced disease does not mean that they are palliative. There are subsets of these patients who respond very well to treatment and can be cured. So really, it doesn't happen over 40. And it's really in this very much the similar age group to osteosarcoma, except even younger. And there's some debate about, you'll see later on that some of the prognostic factors are one of the prognostic factors is age, and anything over 15 years of age has a poorer prognosis. So it's really a disease of younger people. Okay, so the 8 to 13-year-olds, slightly younger than osteosarcoma. Okay, this point about it being a metastatic or systemic disease is important because we shouldn't compromise local treatment. Okay, but the chemotherapy takes the stage really in Ewing sarcoma, as does radiotherapy. The oncologists have a slightly higher edge over us. And what the point I'm trying to make is that if you have a Ewing sarcoma, you need to treat the systemic disease first. And if your limb salvage is going to delay that, then one really should seriously consider amputation. Amputation has the negative effects of course, an amputation, but it does have some positive factors in that it's a once-off surgery. You will have predictable more predictable wound healing, and the patient is in and out of hospital in relatively predictable amount of time and can start their chemotherapy as soon as possible. Another difference between Ewing's and osteosarcoma is that it's more common in whites, and Professor Hoffman used to say that it just did not happen in black people. He has not seen a black person with Ewing sarcoma, and look, I'm still early in my career, but I must admit I haven't seen it. That patient I presented earlier was a colored lady. So, yeah, I haven't seen any Asians. But apparently the literature, Ewing sarcoma is not popular in that part of the world. Presentation again is centered around pain, again often of a month duration or months duration. Remember those clinical signs of a worrying diagnosis being a soft tissue swelling that is deep, firm, immobile, usually non-tender. Because these osteosarcoma and Ewing's occur around the joint, when it may have joint range of motion may be affected. Spinal compression is also an issue, and constitutional symptoms are a sign of advanced disease and only occur in about 10 to 20% of the time. Flat bones. Okay, so we can safely say that osteosarcoma has a predilection definitely for around the knee, being distal femur, proximal tibia, proximal humerus. But Ewing's likes flat bones. Flat bones, obviously the pelvis, scapula, ribs, okay? And it's got a much higher predilection for the spine than it does for the appendicular skeleton when compared to osteosarcoma. There's some percentages I've given you there. And these images may help you to remember the radiosensitivity of a Ewing sarcoma, the top being pre-radiation, the bottom picture being the same patient, a slightly different slice. Obviously the MRIs are taken weeks apart, months apart. Same patient, but you can see the fantastic tumor response. I'll point it out now in case it's not obvious, but this is all tumor. The patient had chemo, radiation, and this is the tumor here. Now, if you're going to be a sarcoma surgeon, the principle here is that one's bony transection points need to be based on the pre-chemo and pre-radiotherapy scans, because it is thought that if you don't get 100% necrosis, you don't want to be transecting through diseased bone. The other thing about Ewing's, and there seems to be lots of points that I'm making between Ewing's and osteosarcoma, is that the soft tissue component, as we can see in that first picture, in a Ewing sarcoma is much greater than an osteosarcoma. If you see a large soft, and that's also why that first case is also discordant, but if you see a very large soft tissue, a tumor with a large soft tissue component around the diaphysis or the fat bone, don't forget ribs. That's it's often a Ewing's. Workup very similar to osteosarcoma, including labs and staging. I'm not going to repeat that here. The radiographically, again, very similar. I mentioned onion peel previously. That first slide on the other talk was much better than the example that I have here. And the last thing is that it's that soft tissue component, or the matrix, is not often calcified. So if you see some blastic component to it and you're not sure between the two, you can lean towards osteosarcoma. People, again, just to reiterate that PET-CT is quite a popular investigation, gaining popularity, and it's usually now a PET included with CT. You do get them separate from each other, but it hasn't won over bone scan in terms of diagnosis of metastatic disease. What it has done is, just to reiterate, it has allowed us to monitor our treatment response. So we do a bone marrow aspiration in patients with Ewing sarcoma, and that's to see whether the disease burden really. And we do a bone marrow. So why do a bone marrow? Why not do an MRI scan? Why not do a bone scan? Because there's often not a discrete lesion. You know, we're not biopsying a lesion in the sacrum, we're biopsying the bone marrow. And our MRI and bone scans, they rely on signal intensity really from deposits of tumor. And if you've got, if you don't have a deposit, these aren't going to come up as positive. Okay. Also, difficulty in children is there's a lot of, they're growing. These are young patients, remember, younger than the usual age group of osteosarcoma. They're producing their own blood colonies. So there's a lot of hematopoiesis going on. And sometimes it's very difficult to assess on MRI whether this is tumor change or whether it's just normal red marrow. If your bone marrow is involved, the prognosis is worse. So biopsy, I won't go into the principles here as it's discussed in an earlier lecture series, but just to mention that we do a core sample. We don't do open biopsies 99% of the time. We get enough tissue, take enough tissue, because of these chromosomal abnormalities, we might need to do more immunohistochemistry and molecular genetics in order to help distinguish between different families of tumors in the Ewing's family. The slide here shows immunohistochemistry. So although you see some small round blue cells, but you also, that brown that it's taking up is the immunofluorescent label that they've used for the immunohistochemistry. The other thing to note with Ewing's, when you're doing a biopsy, remember the old adage about culturing every tumor and biopsying every infection. Definitely send away for culture, because the very high on the differential is an acute osteitis. So the differential includes, as I mentioned, osteitis. LCH is Langerhans cell histiocytosis. And remember, that's a new name for that group of tumors, which was a bit confusing before. Well, may still be confusing, but includes eosinophilic granuloma, Langerhans cell histiocytosis, and histiocytosis X. Those are all now called LCH. GCT can look a bit like Ewing's in the early stages. And then the malignant one that I'll just draw your attention to is lymphoma and leukemia, especially in this age group and especially with this histology. UPS, or undifferentiated pleomorphic sarcoma, that's a little bit of a dustbin for a lot of diagnoses. I've included these pictures on the slide to try. These are pictures of a patient with lymphoma. You'll see that he's skeletally mature, so you may argue that it's not appropriate here. But this was his chest X-ray, his pelvic X-ray. And if I had to put money on it, I would have said there's probably, he had hip pain. There's something probably going on that hip, but you'd be wrong. It's other hips, and so these are quite subtle differences that one needs to be very aware of. That's a bony, well, it's a lymphoma patient, so it's not really a metastasis, but it's just another lesion. And then he has a very large soft tissue component. So these can look very much like, if you excluded that, very much like a Ewing's and a flat bone, and it's part of your differential. Metastatic disease is very similar to osteosarcoma, goes to lung and bone marrow. Funnily enough, of bone, the spine is the most common, as we saw on that slide where we broke up the different parts where Ewing's arises. The pelvis, because it's a deep part of the body, because it's not readily palpatable, unlike your knee, patients often present with more advanced disease and metastatic disease, like this patient's chest X-ray here, where there's florid metastatic disease. Okay, and he had a pelvic Ewing sarcoma, and that's because he presented late, because you don't get the normal soft tissue swelling, the normal pain, the normal joint being affected, etc. So if you have, these are 5 things which you can use LDH to help predict your chances of metastasis, and they go in increasing increments. You've got a high LDH, you've got a 4% chance of having metastatic disease. If you've got a lytic bone lesion and it's Ewing's. If you've got LDH and a fever, it goes up to 23%. And if you've got an interval of less than 3 months, or sorry, more than 3 months, then it goes up to 44%. If your age is greater than 12, then I remember I said in the beginning, there's some discrepancy in where that cutoff is, being at 12, being at 15, being at 18. But if your age is more than 12, your chances of having metastatic disease goes up. Because all of these things correlate with the volume of disease. And we'll see it when we talk a little bit about prognosis, how volume of disease is important. Here we go. So metastatic, if you have bone and lung, it's worse than bone only, unlike osteosarcoma, where if you had metastatic disease in the bone, your prognosis or your 5-year survival is 10 to 15%, where if you had lung, it was a little bit higher, about 25 to 40%. If you have bone only, this is confusing. If you have bone and lung, it's worse than bone only. But if you have bone only, okay, so yeah, so if you have lung and bone, it's worse than just bone only. So it's basically less than 10%. And having bone only versus lung only, so having lung only is a better prognosis, being 30% at 5 years. Sorry, I didn't make that clear. I'll just summarize it again. So if you've got bone and lung, it's worse than bone only. So basically, if you've got bone and lung, it's the worst, it's less than 10%. If you've got bone only, it's worse than lung, being 10 and lung being 30. Location, if it's in the spine, very much like osteosarcoma, it's worse than the extremity, and this really has to do with surgical access and achievement of a wide margin. It's size, so one can measure the volume of these tumors using certain algorithms on MRI scan. And if you're more than, and again, there's a little bit of variance, I know it's annoying, but if it's more than 100 mils, some studies say 200 mils, or bigger than 8 centimeters, then it's a poorer prognosis. And this has to do, again, with surgery, accessing these lesions and resecting them with a wide margin. Age, if you're older, you have a poorer prognosis. Some studies say 12, some 15 or 18. I take it in the middle of being 15. Your response to therapy, which will include your percentage necrosis, and the presence of chromosomal translocations. So this is probably the least important one to know, but there are slight variances in chromosomal translocations, and if you have a certain one, it can be worse than another. Treatment, and that's, just remember that last slide, because it's going to come into, sorry, last point on that slide, because it's going to come into treatment. Because in some people are now starting to try to identify these genetic subtypes of Ewing's and tailor chemotherapy to those subtypes. Okay. The treatment of Ewing's is really based on this concept of risk adaptive therapy, where treatment is selected for these patients based on these prognostic indicators, and drugs are added according to the prognosis. So the worse the prognosis, the more drugs might be offered to the patient. The more aggressive one might be with the radiotherapy and the surgery. The SEER database is a database in the US. It stands for Surveillance, Epidemiology, and End Results. It gathers a lot of information, on all types of cancers. And what it's shown is that there can be these, okay, don't worry about this chimeric transcripts, but differences, subtle differences in these chromosomal translocations that can be useful for treatment, and one can tailor chemotherapy to those translocations. A major difference between treatment of Ewing sarcoma is not only in the fact that Ewing's is radiosensitive, but the treatment is also very different in terms of the type of chemotherapy drug that's given and the length of chemotherapy. So you can see here that, remember, osteosarcoma was cisplatin and adriamycin, or doxorubicin. Remember, those two names are synonymous. Here we're given vincristine, doxorubicin, cisplatin, and some centers will add ifosfamide and etoposide. That's, again, not important, and I don't think we need to know it. You just need to know that the chemotherapy drugs are different. Here, remember, in osteosarcoma, there were 3 to 5 cycles of neoadjuvant chemotherapy, then surgery, and then it was the same for osteosarcoma as adjuvant chemotherapy, the same number of cycles. More if the prognosis wasn't as good, or if the percentage necrosis wasn't high. But here in Ewing sarcoma, you can see we give 14 to 17 cycles of chemotherapy. And that often takes, again, 2 to 3 week cycles, or 2 to 3 week periods in between cycles. But often this is a year of chemotherapy and a year of side effects. And it is a long road for these patients. What the oncologists do during chemotherapy is to, especially preoperatively, is to monitor response. And some of the things they look at are pain, size of the lesion. Remember, we saw that pelvic MRI with that tumor decreasing drastically in size. Some centers monitor the LDH. We will re-image, and then of course they look at percentage necrosis in the resected specimen. So what happens if you, similar to our patient at Red Cross at the moment, if you get a percentage necrosis that's not as high, well then you can add drugs like the ifosfamide and the etoposide, and you can increase the dosages. So if you sort of remember a little bit of the basics of oncology, they work in different ways. Some are cell cycle dependent, some are cell cycle independent. These alkylating agents like cisplatin are the cell cycle independent, and so their dose response curve is similar, somewhere between linear and exponential, where the more drug you give, the higher your response rate. However, there is a ceiling to that, and it's important when considering the longevity of these patients and the future, because if you give very high doses of the drugs, although you may cure the disease now, you may cause secondary malignancies in the future. Another way they've tried to intensify therapy or get a better response if the percentage necrosis is low is interval compression, where instead of 3 weeks between chemotherapy cycles, there's 2 weeks. Okay, and some studies have shown that although you're giving it closer together, the toxicity is similar, and the event-free survival is better. So we talk about different things in tumor surgery. 5-year survival you'll be most familiar with. Event-free survival is another method in which we use to determine the effectiveness of treatment, and that is there hasn't been recurrence in a certain period of time, whether it be 5 years or 10 years. Surveillance, very similar for osteosarcoma. If you do get a relapse, it's often early, and unfortunately that's often a worse prognosis. We usually follow them up like osteosarcomas for 10 years. However, there's some people that think you should follow these patients up indefinitely because of the high risk of secondary neoplasms that often occur 10 to 20 years after the initial treatment. CT versus MRI for the local site. If you suspect recurrence, CT is favored because of metal artifact. However, with the introduction of Mars sequencing, MRI is making a comeback. Because these patients are young, less than 12 often, they have a lot of growing to do. And one of the surgical options, treatment options, reconstruction options that we have is these electromagnetic growers. Unfortunately, they're available to some private patients in South Africa, but on the whole are too expensive really to justify their use. But that is another reason why CT is favored, and that it's not a good idea to put an electromagnet in an MRI machine. Get the patient changing its leg length very quickly. Like lungs, we do a chest x-ray and a CT scan if we're worried about the chest x-ray. Bone scan or FDG PET is the same as osteosarcoma. Most of the disease, if it's recurrent, occurs early, and if they do have relapse, it's a poor prognosis. If you have local recurrence, the majority will also have metastatic disease, and remember this is considered a systemic treatment, systemic disease. I mentioned some of the difficulties about assessing recurrent disease, and don't forget ultrasound. It's a very simple investigation and can be helpful. Some of the complications for these long-term survivors: secondary malignancy from the chemo, from the radiotherapy, pathological fracture. Hopefully we will be publishing an article about that, because these patients get radiotherapy to large portions of their skeleton. Those portions may be left behind. The radiotherapy kills that bone. It's now avascular. It doesn't revascularize, doesn't heal very well, and so patients can get fractures, especially if there's a extraskeletal Ewings or soft tissue Ewings that's been resected and that area has been irradiated. We're getting better with this with newer radiotherapy techniques and pre-operative radiotherapy, allowing us to give less of an area radiation and at a lower dose. Some of the complications with radiotherapy include wound breakdown, infection, pulmonary fibrosis. Often if a patient presents with macrometastatic disease of the lungs, we give radiotherapy because it's a radiosensitive tumor. We get neuropathies because the sciatic nerve, femoral nerve, lumbosacral plexus, they're all around the areas that we irradiate. Limb length discrepancy. If we don't use a grower, if we mess up another growth plate, we don't use growth rest on the contralateral limb and AVN of hips. Those were radiotherapy complications. Chemo complications, secondary malignancy we've spoken about, fertility, basically kidney and heart problems, not to mention the bone marrow problems. And that's it. Guys, I'm going to stop sharing. Again, opportunity to ask a question if you'd like.